Our next talk will be the relationship of social determinants of health with Hirschsprung-Associated Enterocolitis. This will be presented by Dr. Maria Knaus of Nationwide Children's Hospital.
Good morning, and thank you to the APSA Abstract Committee for allowing me the opportunity to discuss our research. We have no disclosures. Hirschsprung-Associated Enterocolitis is the most common cause of morbidity and mortality in patients with Hirschsprung disease. Many studies identifying risk factors in these patients have focused on anatomical and clinical factors, with few studies examining the role that social determinants of health play in Hirschsprung-Associated Enterocolitis. So, the objective of this study was to examine the relationship of social determinants with enterocolitis. A retrospective review of patients who underwent a primary transanal pull-through for Hirschsprung's at our institution was performed. All patients seen at our center undergo an extensive evaluation by social work, and the social worker questionnaire contains a variety of items of social determinants that we queried for use in our study. Examples of determinants that were analyzed include primary insurance type, proximity to the hospital, number of missed appointments, concerns for safety or abuse or mistreatment, who lives in the home, child care, involvement with child protective services, urbanicity, language, and median household income, financial concerns, and food insecurity. A recent scoring system that has reached international consensus was used to define an episode of enterocolitis. This system assigns points to 6 symptoms: fever, bloody diarrhea, obstipation, distension, dilated loops on X-ray, and leukocytosis, with a score of 2 or more being diagnostic for enterocolitis. Fisher's exact tests and Mood's median tests were used where appropriate. Our final cohort included 100 children who underwent pull-through at a median age of 181 days. 23% were female. There was a total of 42 episodes of enterocolitis among 29 patients. 2/3 of these episodes occurred post-pull-through, and over 80% required a hospital admission. The median time of follow-up after pull-through was 2.5 years for the non-enterocolitis group and 3.5 years for the enterocolitis group. There were no differences between these two groups when we examined anatomical and clinical factors. These factors included age at diagnosis, age at pull-through, operative approach, the length of the aganglionic colon segment, trisomy 21, and a family history of Hirschsprung's. We did find, however, that there were several social determinants that were significantly associated with a higher risk. Any child who had at least one episode of enterocolitis was more likely to develop it if they had 1 or more missed appointments. Similarly, children who arrived to clinic via public transportation were more likely to develop enterocolitis, and those who lived in the home with any extended family were more likely to develop enterocolitis than those who lived with just their immediate family. Children who had parents or guardians that were married were less likely to develop enterocolitis. And children who had any involvement with child protective services or any parent-reported safety concern were more likely to develop enterocolitis. Lastly, we found that maternal drug use was significantly associated with a higher risk, with over 2/3 of mothers in the enterocolitis group reporting drug use. Additionally, children whose mothers did not receive prenatal care were also at a higher risk. There were many variables that were not significant, including race and ethnicity, parental unemployment, the number of siblings in the home, and maternal age. Limitations of this study include that it's a retrospective review at a large referral center, so our results may not be generalizable. And while we did not find any significant anatomical or clinical factors, our study may be underpowered to detect these differences. Additionally, the parent-reported nature of our data may introduce bias. So, in conclusion, we found a significant correlation with several social determinants of health and Hirschsprung-associated enterocolitis. Anatomical and clinical factors were not found to be significantly associated with a higher risk, and attention to social determinants in identifying high-risk patients may serve to prevent morbidity and mortality from this disease. With this data, we've created an algorithm to identify high-risk patients. These children and their families receive extra education and teaching and are also given special magnets that the parents tend to love. We also work with Partners for Kids, which is a collaboration between our hospital and the Ohio Medicaid Service to improve outreach to these patients and improve outcomes via home visits, providing medical supplies and education when needed, and coordinating care with other providers. Thank you for your attention, and I would be happy to take any questions.
Dr. Gaines?
I'm Barb Gaines from Pittsburgh. Thank you for bringing that to our attention. I think that we tend to focus a lot on the anatomic and forget that these children, when we discharge them from the hospital, actually have to go to a home, and we expect parents to do a lot of stuff to keep our kids healthy. I was wondering if you've taken a look at, since you've implemented your bundle of interventions, have you looked at whether they've been successful or whether some of the things that you thought would work haven't worked, and if you can give us any insight on that aspect of your study?
Mm-hmm. Yeah, so we have not done that yet. This has all kind of happened pretty quickly where we've implemented the new algorithm. So one of our next steps in this study is to examine whether those interventions are actually helpful in making a difference. We've had good feedback from families, but nothing, no data.
Rebecca Rentia, Kansas City. Excellent presentation and great work. I think it's super important about the care of Hirschsprung's enterocolitis and preventing it. One question for you is, when do you consider it a first visit to return after a pull-through? And what's your current protocol when you say that they missed an appointment? Like, what kind of, was it a created one, or was it like an as-needed follow-up?
Mm-hmm. So in terms of the missed appointments, it was any missed appointment. It could be prior to pull-through, after pull-through, as part of regular follow-up, yearly follow-up. So it was just a general, any missed clinic appointment to our center. Sorry, what was your first question?
Basically, what kind of regimen do you have them on now for follow-up? Like, how soon after a pull-through do you see them back?
Yeah, so for our higher risk patients, we bring patients back first at 2 weeks, and then so it's twice in the first month, so every 2 weeks, and then at that 1 month mark, if we feel that the patient is doing well or that the parents are reliable, then we bring them back as needed and at longer durations.
Thank you.
Hi, Jim Pierce from Valley Children, Central California. So there's a lot of difference between causality and correlation. I sometimes wonder if the enterocolitis is an impressive risk factor for challenges in your social life. And I was wondering if you could make a comment about additional resources that are provided for patients after they get enterocolitis, as it may have an impact on their home life and their ability to get to appointments.
Mm-hmm. Yeah, there definitely is an interrelatedness between the social determinants and enterocolitis. It's difficult to say, that one causes enterocolitis or enterocolitis causes this. It's very complex. So in addition to some of the things that I mentioned in our presentation, like the algorithm and Partners for Kids, because missed appointments is a big deal. Another thing that we do is we work with Help Me Grow, which is an Ohio Department of Health initiative, and that kind of helps with children who maybe don't have Medicaid. It can be for any child in the state, and so that's another thing that we do. We also have, when the patient leaves the hospital, we have a handbook, a binder that has a ton of education that's given to the families. They have to be able to show us that they can perform rectal irrigation, so they have multiple teachings by nurses and nurse practitioners, and they have to essentially pass that before they can go home. We encourage all the family members, anybody that's in the hospital, to be able to perform those irrigations. Additionally, we have, our center has essentially 24/7 access. So if a parent is concerned, they can call in to that number and either get a provider or a nurse practitioner or a nurse who can triage the problem.
We have time for one final question.
Thank you very much. Ayla Stanford, Philadelphia Health and Human Services. One, I have a comment, and the second is a question. With health equity, I think we have to be very careful about words we use, like if the family was reliable, right? Because we don't know what may have led to why they missed the appointment, why they didn't have transportation. It may be at the time they were working and they needed those funds to pay their rent, for example. One suggestion certainly is that when the children are discharged for 30 up to 90 days, they can get home care visits if that's included in a discharge. And something as simple as an examination, an irrigation to help teach, like we do with wound training and so wound packing and so forth, is something that's an option for all parents. And the other thing, just about the actionable items about transportation and missed appointments. And we talk so much about the social determinants of health, but where do we insert ourselves? The things that we can actually have control over. And oftentimes I hear people say that the outcomes are dependent on things that happen outside of the hospital, but there are many things that we have control over that happen inside. And a simple one, if it isn't happening already, is the home visit, because that would solve your transportation, it would solve your missed appointment, and the compliance and understanding this very complex procedure. But I appreciate you bringing this to our light. Thank you.
Thank you.